Hi there. Thank you all for rocking up to our Thursday evening webinar. My name is Maria Elliott. I'm a pelvic health physiotherapist and I have a clinic in London. And I set up the Mummy MOT in 2015 so that we could train practitioners to deliver the postnatal check that mums deserve. And I work approximately 30 hours a week in clinic and then 2 weekends of the month doing training. So our mission is to help educate and also to deliver relevant resources and for us also to discuss sometimes the pathways or triages that might be missed in the postnatal care. So I'm very grateful to have Dr. Kathryn Levy and Dr. Andrew Klein here tonight, who are going to present on iron deficiency in pregnancy and post-delivery. So I'm going to hand over to Kathryn now, who is a very good colleague of mine who's up in Cambridge. And we do some teaching together, don't we? And we do lots of brainstorming together. And so over to you, Kathryn, and if you could introduce yourself and then your colleague, Andrew. Thank you.
Right, so welcome everyone. Thank you so much for being here. So my name is Kathryn Levy. I am also a women's health pelvic physiotherapist. I did my training in the US where I'm from, and I have a clinical doctorate in physical therapy, but I've been based in the UK now for a little over 10 years, 8 which have been entirely in women's health, and the last 4 which have been in private practice. Now, I met Maria in 2016. I think I was one of the original sort of Mummy MOT practitioners, and I've been providing that service in Cambridge really ever since, alongside other pelvic health services, mainly around sort of endometriosis and pelvic pain, of which this topic is also relevant, although sort of not the scope for tonight's discussion. Now, I met Dr. Klein 18 months after the birth of my second daughter, which was in 2021 when I met him. So still in COVID, but not the initial surge. And I actually met him as his patient. So at the time, I was, like I said, 18 months postpartum, and I was really struggling with lots of vague symptoms, I would call them at the time. And I was quite convinced that I had developed a postpartum autoimmune condition. So I went and I had my bloods done. And I was told by my GP that all of my bloods were normal and that there was nothing to be concerned about. Now, what I've come to realize from this is that normal really means within lab range, which are different, and hopefully something that we're going to talk about a little bit more tonight. But I was unconvinced and I requested my labs and I shared them with a dear colleague of mine who is a dietitian who's also based in Cambridge, who I know Andy works closely with, and she sent me to him. Now, he diagnosed me with severe iron deficiency at the time. I was exhausted. I can describe what only felt like a fever-like chill all of the time. I was incredibly anxious and my hair was falling out, which was very distressing. And he really helped me, and I'm very grateful for that. Now, I went down a less obvious path, which was to have an iron transfusion, which again, I'm sure he'll discuss at some point this evening. And while that obviously impacted my personal life, it really changed my clinical practice almost immediately, because I knew that I was not alone, that many of the women that were coming to me probably had iron deficiency and it was being entirely missed or misinterpreted and therefore left untreated. And it really became a passion project of mine. And I screen all of my clients now for it. I've sent him countless patients in terms of managing it. And I think it's a really important thing that we need to be discussing. So, we have a lot of participants this evening and it's wonderful. So, if you're here joining us as someone who suspects that they're iron deficient, then hopefully you're going to learn a lot and take away a lot from it. But if you're an allied health professional, then something I really want you to take away from is that we are very, we're uniquely placed to be screening for this in our clients. It is well within our scope to be having these conversations and referring onwards. They're looking to us for that kind of help. And if anything, beyond it informing how we treat our patients moving forward, having that diagnosis and having that treatment plan in place is really life-changing for them. So we're going to be looking at iron deficiency tonight. Why are pregnant women and postpartum women more susceptible to it? What are the symptoms? How do you know? And what do you do? So we really want this to be interactive. So, as questions come up, please put them into the Q&A box, because we're going to be addressing them towards the end of the evening, but we're really here to help and to answer anything. So without further ado, I'm going to introduce my colleague, Dr. Andrew Klein. So welcome and thank you for being here.
Thanks very much, Kathryn, and it's lovely to see everybody, even if I can't see you in person. I'm going to share my screen so that you can see my slides. So I hope they're coming up on the screen now. And thank you very much to all the organisers for putting this together, and to all of you for giving up some of your evening to listen to us. And as Kathryn said, this is meant to be interactive. This is not going to be me wittering on for an hour. I'm planning to speak for about 20-25 minutes. And then I'll answer as many questions as you like. So we'll answer as many as we can during the session, then I can answer them afterwards as well. And we really want it to be interactive. We really value your contribution and your questions. So please write them down as you go along, put them in the question box on the Zoom chat, and we will come to them afterwards. So the title of the talk, as Kathryn has said, is we're really looking specifically at pregnancy and in the postpartum period. As Kathryn said, I'm an anaesthetist in Cambridge. You might ask, why is an anaesthetist giving iron to patients and women in pregnancy? Well, we've done about 10 or 12 years of research in iron infusions in patients having cardiac surgery at Papworth and patients having general surgery all around the country. And now our trials are internationally. So we've studied about 5,000 patients in various surgical fields over the last 12 or 13 years. And so my interest was not only in surgery, but also in people not undergoing surgery, but people just around, and including and especially women, because like Kathryn, my wife also had iron deficiency during the second pregnancy of our daughter, and she needed an iron infusion as well. So, it's a very similar story to Kathryn's. So I work also at the Nuffield Hospital in Cambridge, which is on Trumpington Road next to the Botanical Gardens in Cambridge. It's been inspected by the CQC, and it's one of the very, very few private hospitals in the country that's been inspected and rated outstanding by the CQC. It's a new hospital. It's a lovely hospital. It's small. It's bijou. It's easy to park. It's in the centre of town, surprisingly, you might think, with its own car park. And I run a clinic there usually twice a week. And I see all sorts of people, but mostly women. 19 out of 20 patients are women. And probably I see about 15 patients a week who need iron, but also B12 or a combination of the two. So we're going to talk a little about why iron deficiency is so common during pregnancy. And it really is incredibly common. Which pregnant women and which women after pregnancy should we be looking to treat, and how? When should we treat them at that particular stage during their pregnancy or afterwards? And how do we diagnose and treat it? So what are the treatment options, and what are the blood tests that can help us to diagnose iron deficiency? So just going to teach you a little bit about red blood cells and iron first. And really, we're focusing on iron, not about anemia. I'm going to tell you a little bit about anemia, and then we're going to talk for the rest of the time about iron. So red blood cells are used to carry oxygen around your body. That's what they're there for. That's all they do. They live for about 90 days, and we're constantly making red blood cells in the bone marrow from the time we're in a baby in utero to the time we die. And we need iron to make them. And iron is the molecule, the heme molecule that attaches to the oxygen molecule. So they are the hand that holds the oxygen. So red blood cells without iron cannot carry oxygen. So we're really interested in those iron molecules that hold the oxygen and carry it around the body, attached to those red blood cells. So anemia is a condition where you don't have enough red blood cells, and you can't carry oxygen around your body, especially when you exercise. But as I said, what we're more interested in is iron deficiency, because even if you have lots and lots of red blood cells, if you don't have iron, your body will preferentially make red blood cells without iron, and then they don't work properly. They don't carry oxygen around properly. And it's the iron deficiency which causes the symptoms. So it's not the anemia that's the problem, it's the iron deficiency that's the problem, because then the red cells don't work properly and don't carry oxygen around. And that's a big misunderstanding. It's the iron that's the problem, not the anemia. And that's why for the rest of my talk, we're going to talk about iron deficiency and not about anemia. And if you look at your red blood cells under a microscope when you're iron deficient, they're thin, they're measly, they're translucent. You can see through them, and they don't work properly because they don't have these nice iron molecules to carry the oxygen around. So they're useless. So you might have plenty of them, but they don't do what they were made to do. Now, globally, 30% of women around the world have iron deficiency, but 40% of pregnant women have iron deficiency. So it's incredibly common. And 43% of children are born iron deficient because their mothers are iron deficient and can't give them enough iron in utero. So this affects both women who are not pregnant, but especially pregnant women, and especially their children when they're born. So what is iron? Iron is a natural substance from the ground. It's absorbed from your stomach, and it needs an acidic environment to be absorbed. It's contained in meat, fish, green vegetables, tofu, lentils, cheeses, and eggs. It's absorbed from your stomach, carried around your body, and stored in your liver. You need iron to make red blood cells work properly, as I've explained to you. So animal-based foods are the best source of iron, especially red meat, liver, but also chicken, duck, pork, turkey, and fish. They all have lots of heme iron, which is much easier to absorb. Now, green vegetables like spinach, broccoli, silver beet, they have iron, but it's non-heme iron, so it's much more difficult to absorb. The equivalent of about 50 grams of beef mince, you need 5 kilos of spinach. So you need to eat a lot of spinach a day. And even then, it's non-heme iron. So it's very difficult to absorb iron from vegetables, lentils, beans, tofu, nuts, and seeds and grains. Whereas the iron in meat and fish is very easy to absorb. And that's the problem. There are some foods that contain lots of iron and some that contain not so much. And remember, you need an acidic environment in your stomach to absorb it. So foods rich in vitamin C, such as oranges, tomatoes, berries, kiwi fruit, and peppers help you absorb more iron from your diet if you eat them at the same time. So if you're taking iron supplements, you drink orange juice with it, and that will help you absorb the iron. Coffee, tea, and wine reduce iron absorption. So do milk and cheese, because they alkalinize the stomach and stop you absorbing iron. So in cultures where people drink tea or milky tea with their meal, they don't absorb the iron from the meal. So that's a big problem. So iron deficiency is just a condition where you don't have enough iron in your stores. So your red blood cells are still made, but they're made without iron. So they're weak, they're flimsy, they're thin. I told you they're translucent, and they don't work properly. So they don't carry oxygen around the body properly. So therefore, you are living in an oxygen-deprived world, like you're living at the top of Mount Everest. So you've never got enough oxygen around your body, to your brain, to your body, to your hair, to your nails, to your skin, you name it, you don't have enough oxygen. And these are the symptoms that we see. So the most common symptom in 90-something% of women, in a Facebook survey we did of 500 women, was tiredness and exhaustion. The next most common is palpitations and shortness of breath, followed by dizziness, brain fog, where you can't think straight, you're losing your memory, it just drives you crazy because your concentration span is limited, you can't work properly. Then you lose your hair. As Kathryn said, that's very distressing to lose your hair. As men, we're used to losing our hair, but women are really not used to losing their hair. And when they do, because they've got iron deficiency, they hate it. Anxiety, depression. A lot of my patients come on antidepressants, but they don't need them. They need iron. Headaches, migraines, chest pains. People think they're having angina or a heart attack and call an ambulance. Muscle weakness and pain because they're not getting enough oxygen to their muscles. And for the physios in the audience, muscle tears. So if you have no iron, you go lactic very quickly during your exercise regime, then your muscles are swollen afterwards, which is why you get restless legs afterwards. And then your muscles are swollen and you tend to injure them and tear them. So muscle injuries are much more common if you've got iron deficiency. Trouble sleeping, restless legs, kicking your partner in bed. Pica. If you have very, very severe iron deficiency, you're craving ice, crunching on ice. If I see someone crunching on a glass of ice in the pub, I know they've got iron deficiency. It's 98% sensitive and specific. So it's the best test is crunching on ice or craving fizzy water or coal dust or crunched up newspaper or chickpeas. It's this craving because you've got an awful metallic taste in your mouth because your body's desperate for iron. So that's called pica, that crunching on ice or craving fizzy water. And I have people that tell me that they drink gallons and gallons of fizzy soda water a day, and then they have their iron, and 2 days later it stops. So now we're going to specifically go on to pregnancy. Well, what happens when you're pregnant? You have a baby, and the baby needs a lot of iron to grow in your tummy, and it takes up about 1,000 milligrams of iron. That's about a third of your iron stores. So that's a lot of iron. That's presuming you have normal iron stores, which is about 3,000 to 4,000 milligrams. And the problem is if you have low iron stores when you start, your baby starts growing. They need the iron to make their bone marrow, their red blood cells, their liver, your placenta. You need lots of iron, about 1,000 milligrams. And if you haven't got it, the baby won't grow properly. And iron deficiency is associated with fatigue. Well, that's not surprising. Postnatal depression, ability to breastfeed, not bonding with the baby, lots and lots of horrible symptoms. And it's an awful thing to be. It's an awful, awful thing to be iron deficient when you've just had your baby. And it makes the whole thing much more difficult. And it can take years to get better because it takes years to absorb enough iron to replace what you lost during pregnancy. And then especially, of course, if you had bleeding during delivery, and especially if you had a cesarean section where you inevitably bleed 500 to 1,000 mils, but you can have bleeding of 1,000, 1,500 mils if you have a tear or it's all very complicated and difficult, or if you have twins. And it, you know, the more complex, the more bleeding you have, the more of an iron debt you build up. So 1,000 to your baby and then maybe another 1,000 on the floor during delivery. So that's a big debt to build up. So I told you the baby takes up 1,000 milligrams of iron, then you have some bleeding, or you have a cesarean section. And then after the major shock of a delivery, you get a lot of hormones released. And that hormones stop you absorbing iron from your diet for the first 6 weeks after your baby's born. So people are always shocked to hear that, but oral iron in the first 6 weeks after your baby is born is a waste of time because you cannot absorb it from your tummy because of all these hormones that are going around. So you have this iron debt or deficit that has to be replenished. And it usually takes another 9 months if you absorb iron properly to replenish your iron debt. So that is crazy, absolutely crazy. You need at least 9 months to get your oxygen, your iron debt back up after your baby is born before you have enough for the next baby. So I told you normal pregnancy and childbirth requires another 1,000 milligrams of iron, but you can bleed and require another 1,000 milligrams of iron to replace the blood that you lost or have a cesarean section. And in essence, only 15 to 20% of women have enough iron stores to meet those net iron requirements of pregnancy. So really, you can see why it's so common. 84% of healthy women don't have any iron stores by the time they get to the end of their pregnancy, and this persists for up to 6 months afterwards. So you really do need a long time afterwards taking iron to build up your stores. So what are the consequences for the mother if you have severe iron deficiency? Well, infections are much more common. You're more likely to be anemic and need a blood transfusion. You're more likely to bleed because your blood will be thinner. You're more likely to have preeclampsia. You're more likely to be tired, to be unable to exercise, to be dizzy, have headaches, not thinking straight, more likely to be stressed, upset, anxious, depressed. The baby blues is very often iron deficiency, impaired ability to care for the baby and to breastfeed, and maternal health related questions of life variables. So that's how we measure quality of life after delivery of the baby, and iron deficiency makes them all worse, both general health, physical energy, and mental health. So it's bad for your body and bad for your brain. What about for the baby? Well, it's not surprising it's bad for your baby. Babies tend to be smaller and lighter when they're born. They tend to have neurocognitive impairment, which can persist for years, including memory, cognition, and behavioral deficits. So it's not good for you, and it's certainly not good for your baby. Now, I've told you it's very common in pregnancy. It's also more common in athletes, particularly runners and people who do boxercise or any sort of aggressive, so these very energetic exercise. I've told you it's much more common in women than in men. So 95% of my patients are women. Why? Because women have periods and babies. That's just a fact. It's a biological fact. So they use a lot more iron. And if they have heavy periods or very heavy periods and they lose a lot of iron, then they get pregnant, they lose a lot of iron. Then they start periods again and they lose even more iron before they've caught up. So it spirals and continues spiraling after you've had your baby when your periods start again. And of course, if you're vegetarian or vegan, which is a very healthy lifestyle, except for micronutrients, because I've told you that the iron in vegetables and vegetarian food is non-heme, it's much more difficult to absorb and you need a lot more of it. So you need gallons and gallons and gallons of spinach and kale to make up for a tiny amount of meat. Now, I'm not saying that vegetarian and veganism is bad. In fact, it's extremely good. And there are a million vegans in the UK, which is phenomenal. But you really have to look at supplementation and testing if you are a vegetarian or vegan woman, and especially if you're a vegetarian or vegan woman and you're planning to get pregnant or you are pregnant or you've had a baby. It's absolutely essential. So in pregnancy, there are different time periods, which we divide into trimesters. So we divide the first 3 months as the first trimester, the second 3 months as the second trimester, last 3 months as the third trimester. So ideally, you've had plenty of iron before you get pregnant or as soon as you do get pregnant. And ideally, all women would be screened for iron deficiency in their week 12 bloods. And it's critical for the baby's growth and neurocognitive, that's their brain and their nerves and their spine, in the third trimester. So that's the critical time for the baby when they need the iron. So the woman needs the iron for the baby to grow, and the baby needs the iron for their brain to grow in the third trimester. So that's really from week 30. So when should we be testing and treating? How do we optimize it? Well, we should be taking bloods for iron at week 12. Then we should be taking bloods again at week 30, which is the beginning of that third trimester. And we should be optimizing women before they get to that third trimester and urgently if they're in that third trimester and they're iron deficient. So you've got 30 weeks to get you've got time to get your iron supplements in and to try them and see if they work. And we should be testing women at least twice during their pregnancy. So the first trimester, if women have got iron deficiency or iron deficiency anemia, simple, cheap, easy oral iron. But then they need to be tested again at the second trimester to make sure the oral iron has worked. If the anemia has got better, they've just got iron deficiency, they can also still have iron. But if the anemia hasn't got better, then they need IV iron. And when we get to that critical third trimester and they're still iron deficient despite supplementing, then it hasn't worked. So there's no point carrying on with something that doesn't work. And if it hasn't worked for the last 20 weeks, why was it going to suddenly start working in the last 10 weeks? So that's the point where women particularly need IV iron. So in about half the regions of the UK, the obstetric services will give intravenous iron to women at week 30, 32, if they're still iron deficient or anemic. That means in the other half of the regions in the UK, they won't give IV iron to women in that third trimester at the critical point for the baby. And that's the problem, that there's a bit of a postcode lottery in terms of what treatment is available to women during pregnancy. And then after pregnancy, virtually no one can get it. And that's also a big problem. So although the NHS will certainly pay for it when you are pregnant, they're very reluctant to pay for it after pregnancy in that first postpartum period when I've told you it's critical. So how do we measure iron? We measure it using a molecule called ferritin, which is a reflection of iron stores. It's like your petrol tank. So if your ferritin is more than 100, you've got a nice full tank of petrol. And that's really what you want to be starting with when you get pregnant, because you've got plenty of iron to make your baby grow. Then when your ferritin falls less than 50 is when you start to get symptoms. So you start to get tiredness, fatigue. At 75, your hair starts to fall out. So that's one of the earliest things. At 50, tiredness, fatigue. At 30, restless legs. At 10, you're in the red zone and your car is shuddering to a halt. So you're shortness of breath, palpitations, you can't get out of bed, you're going to sleep at 4 o'clock in the afternoon and you just can't do anything. So less than 10, you're in the red zone, you're crunching on ice. And that's awful, awful, awful place to be. You feel absolutely dreadful. So less than 50 symptoms, less than 50 if you're an athlete and you're a runner or an Olympic athlete or a swimmer or a cyclist, that's when you have a reduction in endurance. So elite training programs will test women yearly, running clubs, all football clubs, you name it, they'll test their women athletes and look to replace their iron stores if their ferritin is less than 50. So what we recommend is if you do have problems, you should be checking your ferritin yearly, at least, and certainly checking it twice during pregnancy and once afterwards, 3 months after you've had the baby. And if your ferritin is low, if it's less than 100, oral supplementation for 3 months, and then check it again. You need to make sure that these oral supplements are working. They're cheap and easy, but are they working? And that's the key. Is it working? So oral iron is cheap and easy, but it takes time to work. 2 months after you start it, it starts to work. And you need 9 months to replenish your iron stores. So 9 months of oral iron during pregnancy and 9 months of oral iron after you've had your baby, and you'll be back up to full stores if it works. Unfortunately, half of people will get lots of side effects when they take oral iron and they hate it. So the best dose of oral iron is 1 dose, 1 tablet every other day with a glass of orange juice in the morning between meals. Then you have an acidic stomach and you're more likely to absorb it. So not 2 tablets 3 times a day. That would just give you constipation or diarrhea, black stools, tummy pain, bloating, and make you feel dreadful. So 1 tablet every other day, or 1 tablet every 3rd day. With iron, less is more. You need a little bit regularly rather than a lot, and that will reduce the side effects. Now, if oral iron doesn't work, we've got an alternative, and that's called intravenous iron. So intravenous iron we use if oral iron doesn't work. If you've had it for 3 months and you've still got iron deficiency, then you need to try something else. If the oral iron is giving you severe constipation or piles or fissures or prolapse, anything that makes it the result of constipation, or it's giving you tummy pain, and as I said, about 50% of women will get these side effects. Or if you can't wait for oral iron, there's no point starting oral iron at 32 weeks during your pregnancy, because it ain't going to work in time for your baby to be born, and your baby will have problems, and so will you afterwards. And if the oral iron hasn't worked, that's when you need intravenous iron. Now, it used to be thought that intravenous iron was dangerous. It used to be dangerous 20 years ago, but some clever people went away, purified it, and bioengineered it. So they coated the iron molecules in a sugar shell, a bit like a Malteser. So the iron is inside the sugar shell and your body doesn't recognize it. Now, this is an epically labor-intensive process because every molecule of iron has to be coated in a sugar shell. And it's done in a factory, sterile environment, a bit like where baby food is made. So 2,000 people work in this factory. There's one in Copenhagen and another one in Switzerland. So we don't make it in the UK. And all these people are dressed in sort of sterile clothes in a factory environment with hoods, and they make the oral iron and then they cover it in this sugar shell, and that's bioengineering. So the bioengineering process was developed in Cambridge, and then it's being used for iron and many other products. Cancer drugs are bioengineered so that the body doesn't recognize it. So the body doesn't recognize the new intravenous iron products, so you can have it and you're safe. So we give it in a drip arm, like this arm you see at the bottom of the picture, over half an hour. Slowly, we check your blood pressure, your ECG, your blood saturations, your oxygen saturation. It's very, very safe. You can read your book, go on TikTok, watch a movie or chat while you're having your infusion, and we'll look after you. It's very, very safe. The chance of something bad happening is 1 in 250,000. So to give you an idea of 1 in 250,000, that's the chance of you being hit by lightning if you go for a walk. So it's rare, it still happens. So 8 million people have an iron infusion a year in the UK, so it's pretty common, but 1 in 250,000 will be a few. So you will read about it in the Daily Mail or on Google. So it is a very, very rare chance of an allergic reaction. That's why you have the intravenous iron in a hospital, which has all the facilities to look after you. You don't want your intravenous iron in a car park or in a GP surgery. Not that there's anything unsafe about a GP surgery. They don't have the facilities to treat your anaphylactic reaction if you have one. For most people, the side effects are very mild. Some people, their blood pressure drops a bit, which is why we measure it. Some people get a bit of a red face or feel a little bit weird. Quite a few people get an iron flu for a week afterwards, where they feel a bit heady, a bit hot, a bit shivery, and that settles after a week if you drink lots of water and you have paracetamol. And it's ultimately safe for the baby. In fact, it's beneficial for the baby because the baby will love it. They'll be sucking that iron up and growing, and it will be good for you if you're having breastfeeding the baby, because they will continue to get iron afterwards. So ultimately, you won't have an iron deficient baby, and they'll grow better and they'll, develop better. So iron is safe for the baby. It's good for the baby. Safe for mums. I told you iron problems are very rare. It's expensive. You're going to say, how much does it cost? It costs 800 quid. Why does it cost so much? Because the drug is bioengineered. It takes a lot of labor, a lot of scientific know-how to make it. So it's expensive. And then the hospital where you have it, the nurse, the doctor, everyone who works in the hospital, the cleaners, the clerks, the nurses, everyone costs money. So the hospital costs money. So that £800 is a reflection of what it costs. And that's why the NHS is extremely reluctant to do it, because it is so expensive. And of course, the resources, the hospital outpatient beds or trolleys or whatever you have are very difficult to get hold of. We're very resource limited at the moment within the health service. So that's why I set up a private clinic, basically, so that people can have it. You'll say, well, this is unfair. Only people who can afford to pay for it can have it. But unfortunately, at least they can sort of save and know what the costs are and at least have it in a safe environment. And we are researching and petitioning Parliament and working all the time to try and get this provided more for women around the UK. And as I said, about half of postcodes in the UK can have it if they're pregnant. Unfortunately, the other half can't. So if you do need it, we would want you to petition your MP and help us join the campaign to get this more available for women in the UK. And unfortunately, we live in a sexist environment where women's health is not top of the political agenda, but of course it should be. So what we could be doing is getting women's health and treating women and making them healthier top of the political agenda. So I've told you that iron deficiency is very, very, very common in pregnancy. Many women will respond to oral iron, especially you've got plenty of time. Pregnancy, you've got 9 months to have oral iron and another 9 months afterwards to catch up with your iron debt. But the oral iron may not work for some people. So we need to check their iron deficiency with ferritin at the beginning and during their pregnancy and 3 months after they've had the baby to make sure they're replenishing their iron debt and they're ready to, be a new mum. Start getting fit again, start doing things again. And you can't do all that if you're iron depleted. And I've told you how awful it is if you have iron deficiency. So I'm exactly on time. It's 7:32. I said I'd speak for 25 minutes. So both my daughters have been listening to my talk, so they're waving at you. They're not yet board sensors. So both my cats have been wandering around. So I'm sorry about that as well. And I'm happy to take any questions. So I'm going to stop sharing my screen.
All right. Can you hear me?
Yes, I can.
Thank you so much. And hi to your little humans over there. They've been very well behaved. First of all, thank you. Thank you. I mean, we've had questions coming in. I have questions. Maria probably has questions, but I think in general, it's been really, really helpful. And again, I think pregnancy, I'm going to start the first question off. So in terms of the pregnancy guidelines, because a lot of us are allied health providers and we see these patients at sort of 12 weeks, 20 weeks, maybe, 32 weeks. And they're coming to us. And I think, we probably will be the ones that are sending them off for bloods, because they're not getting them done or they're getting done and not being told what the results are and all of that. So just for clarity, pregnancy, they should be having it tested at 12 weeks, yep. Retested at 30 weeks. And then
definitely as a minimum. But if their 12-week was low, then it makes sense to check them at 22 weeks. If the 12-week is normal, then the second blood test is at 30 weeks. And if that's normal, job done. But if the 12-week is abnormal, it makes sense to supplement them and check it 8 weeks later, so 20 weeks. And if they're still low, then that's when you should be considering something else because it hasn't worked. But if it's improving, that's fine. And then you check them once more at 30 weeks. So that 20-week one is really for those who the first test was abnormal.
So ferritin levels in pregnancy ideally are above 50?
Yes. And even better, above 100 before you start.
Okay. Most people not. So on the other flip side of that, postpartum, I think it's really good for us to hear that, well, it's probably not great for some of maybe the patients in the group to hear that for the first 4 to 6 weeks, that iron supplementation is useless. But it's usually when women are taking their iron supplementation, they stop at the 6-week week postpartum. So let's just assume that that's all for wash. They should be getting bloods done at 12 weeks postpartum.
Correct.
And then again, 6 months postpartum, or are we waiting potentially until 9 to 12 months when we assume that they've restored or ideally, and then kind of assess from that point?
Yeah, so correct. 3 months postpartum, definitely. You know, if it's normal, then there's no need to repeat the test because they're not bleeding and they're not, you know, they're not pregnant. But if it's abnormal, then definitely again at either 6 or 9 months, depending on how abnormal it is. And, you know, ideally, I really go with this idea of an MOT. Ideally, women should be checked out at a time postpartum, maybe 6 or 9 months, so that they can make sure they're ready to, you know, that's a really important time.
Yeah.
And part of that is checking their iron levels are important, because how are they going to start building up their pelvic floor, getting exercising, getting fit again? You know, they've had a difficult 6 or 9 months, breastfeeding and so on and so forth, but things are starting to settle down. And that's when they need to be really focusing on their own health so that they can, you know, really get out there again. So I think 3 months and then maybe 9 months again, you know, another 6 months and after 9 months. So that mummy MOT should include some testing, as you do, Kathryn. I mean, it's not a criticism, because if you're abnormal, how can you do the physio or whatever else you're doing?
No, and I think that question is coming up in terms of what the guidelines are from returning to activity if you're suspected iron deficient or confirmed iron deficiency. Andy, can you see the questions? You can pull them up, yeah?
Yeah, I've got them.
So shall we start with some of them? I mean, I could ask you questions all day, but nobody wants to hear me talk. Let's see. Right, so from David Kronk. So ferritin is an inflammatory protein. Does it rise in pregnancy irrespective of iron store?
So yes, David, you're quite right. It is an inflammatory protein, and it tends to be elevated in infection, like COVID. It stays up for 3 or 4 months after you have COVID. And it also raises during any sort of infection, but particularly chronic infections, chronic inflammations. Pregnancy is not a chronic inflammatory state, so your ferritin does not raise during pregnancy unabated. It only raises if you've got something else going on. So generally it falls during pregnancy as you're using up your iron. So if it's raised, if it's 200, 300, and it's abnormal, you're thinking, oh, these are great iron stores, we do a transferrin saturation as well. And that needs to be more than 20%. So very often, if I think the woman has got iron deficient, but the ferritin is high, you're thinking, well, what's going on here? This doesn't make sense. Then we do a transferrin saturation as well. So many of the home testing kits from various companies like Medichecks or Thriver, I don't know how you pronounce it, they will do transferrin saturation and ferritin at the same time. The NHS, in its infinite wisdom, doesn't, and you have to request them separately. They cost a small amount of money each. So transferrin saturation helps with the specificity of the test, as David says. It helps you determine if the woman is artificially, you know, has a high ferritin for another reason and still has iron deficiency. But in pregnancy, it's a low ferritin is a pretty easy one.
Yeah. So
and that answers Sharon Kelly's question. If referring someone for blood tests, what should we ask the GP for? So ferritin and transferrin saturation for iron. B12 and folic acid are both incredibly important during pregnancy for nerves, for the neural development of the baby, their spine, their brain. So B12, folic acid, iron, ferritin, and transferrin saturation, and hemoglobin, because anemia is also important. But as I said, I'm more interested in the iron status and the vitamin B status than I am in the anemia as such.
So, gosh, there's so many. Where do you want? So, right. So, any risks to having an iron transfusion in pregnancy?
No, it's safe for the baby. It's safe for the mother. The only risk is if you have an allergic reaction, which I've said is incredibly rare compared to antibiotics. And lots of pregnant women might need antibiotics. So that risk of an allergic reaction is 1 in 80,000 with antibiotics, whereas iron is 1 in 200,000. So yes, it's incredibly rare to have a problem.
Yeah.
You still have to have it in a hospital and be safe, but it is safe.
And I think I would add to that, especially for women who are planning elective cesareans or have had histories of hemorrhaging before in the past, having these labs checked before you go into either another delivery or surgery is really important, and it's kind of a risks benefits. And I don't know that women are ever sort of educated on that or informed enough to make a decision about that.
So Harriet's asked, can anemia cause miscarriage? Absolutely. If you're iron deficient, the fetus, the embryo will not implant. So you often have miscarriages if you're extremely iron deficient. It's not surprising because it's to do with oxygen delivery and carriage, and the growing baby is an end organ. So you need a lot of oxygen to be carried to the growing baby. So iron deficiency is associated with failure to conceive and with miscarriage, both early and late. So one of the things that you should be tested for if you're having recurrent miscarriages or failure to get pregnant is iron deficiency. And that's a really important thing to test for if people can't conceive, or it's an awful thing to lose your baby, and that's a really important thing.
I was just thinking that, do you pre-screen when mums become pregnant if they'd had a history of, say, ice eating, or because you often see it in the endometriosis world, don't you? And again, there's that fertility challenge plus the loss of blood, etc. So is there anything that we should ask in that like 12-week pregnancy screen? Like we often say, do you have a history of endometriosis? Do you have a history of urinary tract infection, painful bladder syndrome? So if you had somebody who did eat ice beforehand, I presume they're just deficient in iron, are they? And they should, yeah.
Yeah, and then they need it. And if they've had a miscarriage or can't get pregnant, they need the iron. If they don't absorb the oral iron, they need the intravenous iron. So I get a lot of patients who say they can't conceive. They have their intravenous iron. 6 months later, boom. I mean, It's not really surprising. You need to be well when you're trying to conceive. And being well means that you've got lots of micronutrients on board, because it's such a complex thing getting pregnant. It's not surprising. If the man or the woman are iron deficient or unwell, it doesn't work. I mean, it's just not surprising, is it? You need to be in a well state. And if you've had a baby or you've had a miscarriage, then you need to be well before you start again. And that includes replenishing your iron stores, which have been lost.
Yeah. All right. Keep going down. How long before you start to feel the effects of treatment?
After an intravenous iron infusion, 4 weeks. So you feel a bit of a fluey, sort of funny feeling for a week. Some people say a week later they feel great. I think the majority of patients 4 weeks later. I mean, do you remember, Kathryn, how long did it take you before you felt well?
I would say probably 6 weeks before I was exercising well, but longer before I felt like my hair was growing back.
Oh yeah, the hair takes the longest, and the fatigue takes even longer because it's non-specific. The restless legs disappear in 2 days, 3 days. The palpitations and the shortness of breath disappear in a week. The hair takes the longest, can take 6 months before you get baby hair growing again. And then before your hair is lush and strong, it's a year.
And what about oral supplementation?
Oh.
How long?
What, for hair?
For anything, just the benefits.
So at least 2 months for you to start, at least 2 months for it to start to work, and 9 months for a good effect. So what you do is you start oral supplements, 3 months later you check. So if your ferritin was 20 and it's got up to 40, that's fine. And then if it's 20 and it's got up to 22, then it's not going to work. So if 20 has got up to 40, you test it 6 months later, it should be at 90 and you're fine. So you've done your 9 months of oral iron. But if it's 20 and it's got up to 22, it's never going to work. Don't just bother taking another 6 months, because if it's not going to work in 3 months, it's not going to work in 6 months or 9 months. So the key is to test and then test to make sure it's working.
Yeah.
It's no point taking it for years if you're not testing to see if it's working. You wouldn't do that with anything else.
Right. And then I think it's also considerations for how long people are willing to wait to feel better, because it depends on the symptom and it depends on what it's holding them back from. So we have very keen athletes coming in for their postpartum checks. They want to get back to what they were doing, and they might decide that they just don't want to wait. Like I knew for myself, I wasn't willing to wait to feel better. Right. So I think it's just something that they just, again, we need to have those conversations, especially as it impacts exercise choice. Yeah. And
lifestyle, and going back to work, and the things that strengthening your muscles, your back. If you have iron deficiency, your back muscles will be weaker. And you can't train them up again. You can't train your pelvic floor up again. If you have iron deficiency, you're not well. So it's not surprising that all the the problems associated with pregnancy, like bad backs and bad pelvic floors, persist if you're not well.
Yeah. Right, let's get through these questions. There's so many. You can see them. Do you want to answer Benita's question, Andy, about antenatal vitamins? Can you see it? Yeah.
Oh yes, antenatal vitamins, pregnant care with iron also contain calcium. What are your thoughts on this? Will it still get absorbed? Well, no, not as well. It's not a great way to do it. So the multivitamins for pregnancy are well set up. So they are set up to be absorbed well. So Holland and Barrett make a good multivitamin that is very well absorbed and has been tested looking at its absorption. So you want a multivitamin that, you know, not any old one that's, you know, going to be absorbed.
Yeah.
Carly says, do we know what postcodes provide intravenous iron? I don't, Carly, I'm afraid. I know they do in Norfolk and they don't in Cambridge and they don't in Suffolk. So I only really know in the east of England. They do in a lot of places in London and not a lot of places up north, because I have a lot of patients that travel from the north of England and Scotland and Wales and Ireland, where it seems to be particularly bad, the NHS care in the devolved nations at the moment for some reason. So a lot of people will travel a long way because they can't get it. But I don't know which ones do and which ones don't.
Yeah. So this is, so Gemma looks like she's had a journey. Can you see this? So is it reasonable? What is reasonable ferritin value to get postpartum to then stop treatment?
You want to get it up to 75 if you can, Gemma. You had very low ferritin levels 5 after your second baby, so that's ridiculously low. You must have felt dreadful. It rose to 23 after 6 months of oral iron. Yeah, that's way too low. You needed to carry on for at least another 6 months. It was going up but slowly, so it was working but very slowly. You then had low ferritin levels in your third pregnancy, not surprising because you were low before you started. You started oral iron 30 weeks too late. And then you kept the oral iron up to 6 months postpartum. You were then told to stop by a practice nurse. You're a runner and you still feel quite fatigued. Well, almost certainly you're still iron deficient and you've never caught up with your iron deficit from your 3 children, I'm afraid. Your running times are slower. Yes, 20 to 30% reduction in VO2 max, which is your maximum oxygen delivery. And if you have iron, your running times will get better by 20 or 30%. I guess you should get your ferritin levels checked again. Yes, you've worked it out. So check and then check again. That's the key. It's a £4 blood test for your GP. If you have it done privately, it's a £30 or £40 blood test, depending on which company you use. The private company sends you a finger prick kit. So you stab your finger, you take 3 drops of blood on a stick and send it back to them. And 2 days later, after you've paid your £40, you get emailed with your results. If you don't want to stab your finger, you can go to a chemist or Sainsbury's or Boots and get the blood taken by a nurse. They add 30 quid on if the blood is taken by a nurse. So it's about £40 to do it at home and about £70 to do it in a pharmacy or a supermarket. I know my Sainsbury's has got a nurse in the pharmacy working very busily doing bloods and all sorts of things.
And
Does it matter at what point in your cycle that you would take them? Okay.
It does vary in your cycle by about 10, so from 30 to 40, but it gets to go down a little bit when you're bleeding, when you're having a period, tends to go up a bit sort of halfway through your cycle between periods, but only a small amount.
Okay, so there's not an optimal time to recommend. Okay.
Not really.
And Andy, can you just kind of say to the group a little bit about what, like, the difference between what lab ranges are and what actual therapeutic ranges are? Because a lot of these people will be getting tested and be told that they're normal.
Yeah, so the normal range that the laboratory puts on the blood result is the range that is 95% of the population. So the laboratory normal range is based on the population normal. So they will look at the normal in the UK, let's say England, for example, and they will look at, say, 2,000 women or 2,000 people, women and men. And very often it's actually based on very more men than women, unfortunately, which is one of the reasons why it's so rubbish, the normal range. But anyway, 2,000 people, and they will say, well, 95% of people have a ferritin between 10 and 250 or 10 and 300. Yes, of course, 95% of people have a ferritin between 10 and 300, but 30% of women have symptoms of iron deficiency, and those symptoms come at a ferritin of 50. And that's the point, because 30% of women have symptoms because they have iron deficiency, but only 5% are outside that normal range. So 2.5% of women will have a ferritin of less than 10.
Right.
But 30% of women will have a ferritin of less than 50. But it's irrelevant what everyone else does. It's only related to the symptoms. So ferritin of 50 is what the symptoms come at, and that's when the the red cells are not made very well, whereas the laboratory is looking at the normal range of the population normal. And the population normal includes those 30% of women with iron deficiency.
Right.
And that's the problem. So you're quoted. So if you only have a small amount of money, you will only treat the worst 2.5%. That's the ferritin of less than 10. So you set your treatment levels at that which you can afford. So if you set your levels at 10, then you'll need to treat 2.5% of women. If you set your levels at 15, you might need to treat 5% of women. If you set your levels at 50, you'll need to treat 30% of women, because that's what the population includes, 30% of iron deficient women.
Yeah, and that's the takeaways, because people are being told they're not iron deficient when their ferritin levels are 11.
Which is nonsense. They're very severely iron deficient and they're crunching on ice.
Right, but they're just above threshold. Right, we're going to run out of time. We've got so many. So let's kind of, so I think current guidelines, we've talked about that. Carly has a question about whether or not she can send people to you. And I think the answer is yes. Doesn't matter where they are, they can come to you, right?
Yeah, they come from all over the country. So if you just go on to www.cambridgeironclinic.com, there's more about what I've said, and you can just book online, and you can come from anywhere. Yesterday I had a clinic with 12 people, and we had Scotland, Wales, Ireland represented, Bath, Bristol, Cambridge, London. You know, people come from all over because they want to feel well, and they're, you know, especially important when you're pregnant or you've had a baby, as we've discussed. But yeah, you can self-refer. You don't need a referral. The only thing you need is some blood tests. So get your blood test done, and then email me via the website, and I'll email you back. And yeah, that's all you need to do. If you're not sure, then that's fine. Well, email me, and I'll include your blood test results, and I'll email you back.
He's very quick to email back too. It's wonderful, very quick. So Sarah wants to know about just having people start oral iron before 12 weeks. If given the percentage of pregnant women with iron deficiency, is it worth starting on some oral iron before the 12-week bloods?
Well, I would go way back then. I'd start it before conception. So we recommend women to take folic acid before conception, don't we? You know, the record. So I would say, in a sensible women's health driven environment or country, we would tell people to take iron supplements and folic acid 6 months before they conceive. Now, of course, you don't always plan to conceive, so start straight away if you're pregnant, especially if you're low. In India, they're adding it to the water. Why are they adding it to the water? Because 68%, so double of the UK, of women in India have iron deficiency, because many more are vegetarians. They boil their vegetables and leach the minerals out. So there's a lot of iron deficiency in India. Then they drink chai, which has got milky tea and sugar with their meals, so they don't absorb the iron. So 68% of women have iron deficiency. In sub-Saharan Africa, it's 80%. So you think we've got a problem in the UK? You go to India or Africa, where it's an enormous, massive public health problem in India and Southern Africa. So, you know, we're talking just about the UK, but looking internationally, this is the world's commonest, according to the WHO, condition.
Yeah. So gosh, looking at these questions. So what about twin pregnancies and normal?
Twice as much iron.
Twice as much iron. Okay. And in terms of infusions, is it a one and done situation?
Yeah, nearly always. It depends really how deficient you are. So if you're very anemic when you started, you've got to make all those new red blood cells and replenish your stores. So very often, if a woman's very anemic, which means she's had iron deficiency for 2-3 years already, so very severe iron deficiency for 2-3 years, you're anemic. At that point, you're falling over, fainting, and going to A&E. So at that point, if I give them iron, they usually need a second dose 3 months later. So if you're really, really, really bad, you might need a second dose. But these new preparations, we give a lot more, much more safely. So usually it's one and done, unless you have another baby who takes another 1,000 milligrams of iron from you, or twins. So really, it depends on each woman, is the real answer. Everyone's different, and their circumstances and their pregnancy and how much they bleed when they have their baby and things like that. Every woman is different. And I think everyone would understand that everyone is different.
Yeah. And I think this will probably be the last one, because then we got to wrap it up. So I think last two. So I think Tanya's question is about YouTube videos. I presume it's about whether or not like on a video to watch about an iron transfusion. I'm unclear about what that is, but we can always ask her to clarify. Last one is, and I think we've already answered it, but worth just clarifying, can iron deficiency still be an issue years after postpartum?
Absolutely. So if your tummy is not great, and there is a lot of women who also have bad tummies, we could spend another hour talking about bad tummies or IBS symptoms or chronic constipation or diarrhea. If you don't absorb the iron very well properly, especially if you don't absorb the iron supplements, this could go on for years and years and years. And I've had people have had 20 years of problems after they've had their children, fatigue, exhaustion. They've been labeled as chronic fatigue syndrome or ME or all sorts of things. And in fact, it's iron deficiency. And then they have their iron infusion and bingo, they feel better. Life is completely different. And life will be completely different. If you're running around with a ferritin of 10 or 20, you're feeling dreadful. And that's the key. Get tested when you get pregnant, get tested during your pregnancy, get tested after you're pregnant, and take a logical evidence-based approach because it's so important to look after your body when you're pregnant. I don't think anyone would disagree on this call how important it is to look after yourself, during and after you've had your pregnancy. And that's the whole point, really. We want to improve women's health and our baby's health, and that's really what we've been talking about.
Thank you so much. Yes, this has really been wonderful. I could listen to you talk for hours. So I really appreciate it. And again, your details will be sort of updated and, the recordings that we send. And I imagine that you will get many emails and that lots of people are going to go off and get blood tests after this.
Good.
Right,
they should do.
They should do. Right. So with that, thank you so much, Andy. And yeah, I think we're just going to hand it over to Maria.
Yeah. Oh, thank you both so much. That was fascinating. And, we've been talking about this this week, actually. I did an Instagram live with the postnatal community talking about, we do a Mummy MOT at 6 weeks and 8 weeks and 12 weeks. But what about the mums at 9 months and when they go back to work? And a lot go back to work, don't they? And they are iron deficient, or they're still in pain, or they're still have continence challenges. So it's perfect timing for us to look at often the missing link. And I was thinking probably I can think of 2 or 3 mums who've had an iron infusion, but I can't think of many. And I see lots of mums. So so fantastic. Thank you so much for rocking up here tonight and presenting on our December masterclass. And then I'd also like to thank our sponsor, FemFit, who are based down in New Zealand, and they have a new biofeedback device for pelvic floor strengthening. And what's really cool about it is it also records the intra-abdominal pressure compared to the pelvic floor. So looking forward to learning more about their new device. So thank you all, and we will send you through the recordings afterwards. And if you need any more information, just contact us. And I'd really like to give a big thank you to Event 7, Sean and his team, who have coached us and spent lots of hours getting us ready for this event tonight. So thank you all. And we'll be doing masterclasses once a month in the new year, and hope that you will come to those. So thank you very much. And if you want more information on the Mummy MOT, just go over to our Mummy MOT website. You can click on the QR code here and get some more information. And just email us at help@mummymot.com if you need any more advice or have any questions after this webinar. And thank you once again for attending. And thank you to the speakers. Bye.